Good morning, everyone. Good morning, everyone. My name is Risha Moskalewicz. I'm a pediatric emergency medicine doctor, as well as the director of global health education for our pediatric residents here at the University of Minnesota. Today, faculty from the Global Pediatrics program, as well as an honorary guest speaker, will be presenting this grand rounds entitled Improving Health Equity Through Academic Partnerships with Native American Communities. Damon Leader Charge is our honorary guest today and is an enrolled member of the Rosebud Sioux Tribe and the Director of Tribal Outreach for the University of South Dakota, his alma mater, where he double majored in Native Studies and Addiction Studies and is currently finishing up his master's degree. Prior to returning to the University of South Dakota, Damon was the Director of Health Administration for the Rosebud Sioux Tribe. I'll now turn over the presentation to him.
Amidakia tokealachi wopilachi chapalo yuha chante washte napechuza papalo ihanilachi. My relatives, first and foremost, I thank you for this honor and this time to build awareness and education. And I greet you with the heartfelt handshake. Here is the University of Minnesota's land acknowledgement. I'm glad that we're covering this. I'll let you read it. I'm part of a work group here at the University of South Dakota in creating our land acknowledgement. We are using University of Minnesota, University of North Dakota, University of Arizona in terms of developing our land acknowledgement, which is directly related to our strategic plan per President Gestring. President Gestring is our second female president, which to me says a lot about the direction we are going. We definitely could have went the usual route, the good old boy system, but having President Gestring and Dr. Hackerman as our provost is showing some great leadership to what should have happened many years ago, more specifically in terms of my position. But with the land acknowledgement, there's also that debate and discussion and argument is where's the reciprocity? And that's some of what we're going to plant in terms of seeds and the direction we'd like to see that go, not only from natives, but also non-natives, colleagues, allies, as such. I'd like to, per our protocol and traditions of the Lakota, Dakota, Nakota, start us. We have it listed as an opening prayer, however, is Wochekye, which is the value of prayer. If you all could join me, I'd like to start us out in a good way. This is what we do at home in terms of any function event that we're having is to give us that good direction from our ancestors, from the four directions. So if you want to, I'm going to pray in my Lakota language. If you want, please close your eyes. Pray for yourselves, pray for your extended families, pray for those that you are caring about, the passion that you have in terms of wanting to help others through healthcare and any other initiatives or endeavors, but please join me in this protocol. O tukashla wa kantanka tukashla tate dopo uchimaka wa mlio yate wa kawa yate leampetu ki wopila chichapolo. Creator, on this day, we recognize, acknowledge the four directions, the four winds, what's above us, what's below us, the Eagle Nation, and our sacred beings, and we give you thanks for that. Wocheki umgaga, tokialakchi wocheki umgaga, boeki haheweki ochlate oyatiki ga hektanaji. We chose in the yuha pikolo tukashla. We start off with some prayers, and we acknowledge all those nations and people under the star, under the moon, and we pray that they have good health and good health. Otunkashla. Lena koshkalaka washi chama over womblas and washtekalo tukashla okiapo. Creator, the young men and the young women, the men and the women that I work with, and this function that we're having today, we ask that you give us good understanding in the future and in our future endeavors. Ijia tiwahe kapi, ijia tioshpe kapi. We chosen a walk long like a Buffalo, and for their families and their extended families that they represent, I ask that you give good health, good help, perseverance, and protection for them as well. Winukchala, Wichakchala, Wakayanza Chichikala, we chosen in Woke Wachitanka, Tukasha, Wangla, Kekupalo. And for our elders, our men and women elders, and our precious babies, I pray that you give them the utmost good health and health. Wotunkashala, Daka Washdek Chewakilo, I pray for all that is going to be good. And I'd like to offer this song at this time. Miya toka haya ampetu yelo wambli gleska heya ya uelo yo hai miya toka haya ampetu yelo yo hai hoy me toka heya ampetu yelo anukasa heya ya uelo yo hai me toka heya ampetu yelo yo hai hoy. Madakia Obmaza Niktalo. I want to live healthy with all my relatives. Midaku Yase, we are all related. Wopila, hello, thank you.
Thank you. Next slide, please. Also presenting this morning will be Dr. Alice Lehman, who's our current Pediatric Global Health Chief. She has worked clinically and as a community advocate for the past year in Rosebud, and will be starting her infectious disease fellowship in July here at the U. Also, Dr. Subrahmanian is a faculty member at Hennepin Healthcare in the Department of Pediatrics, who has also worked at the Rosebud community as a teacher, provider, and collaborator for the past 17 years. And lastly, Dr. Mike Sundberg, a University of Minnesota faculty member in the Departments of Medicine and Pediatrics, has been working in Rosebud for 5 years and has been instrumental in coordinating our academic side of the collaboration. Next slide, please. The mission of the Global Pediatrics Program is to improve the health and development of the world's most vulnerable children in partnership with health professionals at home and abroad to ensure that every child reaches his or her full potential. Next slide. In the 2020-21 academic year, faculty and residents in Global Pediatrics have received and submitted numerous grants, published articles, worked on book chapters, and shared research experiences in virtual conferences. Next slide, please. In the area of education, we have formed new collaborations and found creative new ways to cultivate ongoing quality global health education and international partnerships during and despite the pandemic. Our partnership at Rosebud Reservation was uniquely strengthened this year, as residents and faculty who might have otherwise traveled abroad instead began working at Rosebud. Next slide, please. This collaboration between the University of Minnesota Global Health Track in the Pediatric Department and Rosebud began formally in 2017 when we sent our first resident, and has grown over time with more faculty and more residents participating. Next slide, please. This partnership is exceptional in so many ways, and we're so proud to be able to highlight its importance today. Today's speakers have no disclosures, though would like to emphasize that they are speaking from their individual viewpoints and experiences and are not seeking to represent governmental, tribal, or institutional viewpoints specifically. Next slide, please. The objectives of today's talk are to recognize the ongoing health impacts due to historical and present relationships between rural Native American communities and the U.S. federal government, to identify and describe pediatric health disparities existent in rural Native American communities, to describe entities responsible for providing pediatric care to Native American children, and lastly, to identify areas of educational collaboration toward health system improvement between the Rosebud Sioux Tribe, the Indian Health Service, and the Department of Pediatrics at the University of Minnesota. Next slide.
So here we are beginning with historic and contemporary relationships. I feel it's critical to understand, again, that I'd mentioned, where's the reciprocity at? If we're gonna acknowledge our land, the nation's tribal homelands that we sit upon now, where's that reciprocity? I have to cite a professional colleague and mentor, relative of mine, Dr. Don Moore, who sits on various boards. He's a visionary in terms of tribal public health. He's the director of the Indians into Medicine program at the University of North Dakota, who has some IHS funding flowing through it since the 1970s. And that's the program to grow our own, to have our own doctors, our own nurses, our own healthcare professionals. And in his work, and part of his legacy is sitting on, again, numerous boards, whether it's the CDC, within the HHS, the Human Services Department agencies, and he sits around committee meetings where there's 50 to 100 leaders, and they talk about these great efforts that are going overseas to third world countries in Africa, and nothing against them, but we owe something. We need to give back to our tribes, and he often has to stand up in those rooms and remind those leaders that there are third world conditions in our backyards and our neighboring states. And then, that's what we are dealing with in Rosebud. There are 11 tribal nations. There are 11 recognized, whether it's through the state or through the federal government in Minnesota. And there are also 9 in South Dakota. So it's important to realize that, and also the historical relationships that we have. That's what's really gotten us to where we're at in terms of historical trauma and intergenerational trauma. Next slide, please. Again, we're going to go very far into history in terms, and here's a picture that illuminates manifest destiny, westward expansion, and it kind of shows that it's chasing us off. However, we are survivors. We did resist for many reasons, mostly for our culture, our heritage, and our way of life, and we still do that to this day. I gave up going for a JD, an MD, or a PhD in order to go home and learn from our elders. Well-respected medicine man, AKA medicine man. He was a Yeska, he was an interpreter, last of his kind. He has passed away 2 years now, last October. And I wouldn't be able to do what I do now in terms of the language, song, and the prayer that I shared with you all if it wasn't for him and his teachings. So, we may be running for cover, but we did stand up for what we believed in. Next slide, please. Here's a map of, our traditional tribal homelands throughout North America, or as some teachings tell us, Turtle Island. As you can see, it's very vast and immense. But again, from manifest destiny to westward expansion to this map, I'd like to pose a question. Next slide. In your mind or in the chat, you can answer. This is not to make you feel bad in any way or discouraged, but again, this is where awareness and education begins. I'm going to give you a whirlwind of information. A lot of the topics that I'm touching on are easy semester in each of your respective universities, or within the University of Minnesota. So if you want, you can put it in the chat. I've had the guests of 10, I've had the guests of 1,100. There are actually 574. There are actually over 400 tribes that are on the docket waiting federal recognition. Some of them have a true argument, justification for that, but it takes an actual act of Congress in order to become federally recognized. Federally recognized means that you're eligible for different services through different federal agencies. The agency that we're going to talk a lot about today is the Indian Health Service. Again, these are contracts in perpetuity, or as we know them, treaties that have been set in place generations and generations ago. So this is a good map according to the census 2010, and last POTUS signed 6 tribes into federal recognition. Again, act of Congress, president has to sign off on it. So there was 568 and we're at 574. I even have to look that up every once in a while to ensure that I have the right number. Next slide, please. Here's some key definitions to remember. You're going to hear me utilize Tichango Ogallala Lakota, which is in my personal introduction. Those are the traditional names of the sub-bands that I represent. I used to only introduce myself as an enrolled member of the Rosebud Sioux tribe until my mother scolded me in a really good way, as she should, because I don't only represent my paternal side, I also represent my maternal side. So I'm going to use Indian, American Indian, Native American. Those are treaty terms. I used to hate being called an Indian. I got over that through my Native Studies coursework, and we had some great think tanks, and I had an elder, another fellow non-traditional student state those are treaty terms. So if you contextualize some of these terms, even though we don't like them, we have relatives that have literally fought and died for what we got now in terms of treaties, us being recognized as sovereign nations, having our tribal homelands, aka reservations, in the places that they're at. Next slide, please. Eligibility, that again, that has some, that is very directly, related to being a federally recognized tribe as a sovereign nation. Tribes have the ability to determine their own requirements. If we were in person, I would send this around after I sanitize it, of course, because of our better normal that we're in. But we actually have a blood quantum concept where is very much similar to dogs and horses. The concept is meant to dilute us, and it's meant to erase us. However, there are some tribes, because they are sovereign nations, they have the ability to lower their requirement from a quarter blood to an eighth or even a 16th. So yeah, next slide, please. Here are some demographics. I'll just let you look over them very quickly. Again, we're a quote unquote Indian country. That's a phrase that we use nationally in terms of, again, utilizing our treaty terms. Again, there was a time I hate being called an American Indian, Indian, Native American, Native, Indigenous, because I know who I am. I know where I come from. That's all my elders and my Chioshpe taught me, my extended family. However, I got over that after, I evolved and I matured and I understood where those definitions come from. And a lot of what I say is personal and professional. It comes from my own personal professional experience. I'm not the gospel. There's different teachings. Excuse me. All teachings are to be respected. So if you broke that down to 574 tribes, there's a lot of teachings that you would have to learn. My point is not to homogenize us, because we're 1% to 2% of America. We're usually thrown into a melting pot, sometimes forgotten, and even sometimes alone. But we're still here. As you can tell, we're in a critical time where we are actually producing Native American lawyers, Native American doctors, Native American PhDs. So we are writing our own history and revitalizing the language and other traditions. Next slide. To me, this is a huge map. This is some great information. This is for the Great Plains area, according to the Indian Health Service. We're regioned out according to North Dakota, South Dakota, Nebraska, and Iowa. So I'm going to be utilizing Great Plains area as a phrase now, because it is very relative to the Fort Laramie treaties of 1851 and 1868. These are contracts that we have that ensure that we have a government-to-government relationship with the federal government. So for us, our relationship was with the federal government, not the state, which means we don't have the best of relationship with the state, because again, that's what our contract, that's what our treaty says. So there's again another phrase that is very relative to this is treaty obligation and trust responsibility. We use that a lot because that was promised to us, again, in perpetuity. So the reason I'm showing this slide is our land base according to the Treaty of 1851, and then what it shrunk down to in the Treaty of 1868. Next slide, please. And then what we are here in present day. This is the state of South Dakota and tribal nations in South Dakota. So we literally gave up millions and millions of acres of land, if you could see. So a lot was happening in terms of the Indian Wars pre-1851, between 1851 and 1868, and after. That was our people standing up for what they believed in. We're the only people to defeat the U.S. cavalry, the U.S. Armed Forces, but it was in haste, maybe somewhat in haste, because we were standing up for what we believed in. So this what makes us significant and ensures that our sovereignty is recognized. And we are, as you can see, we lost those millions and millions of acres. If you also counted the timber rights, the water rights, the mineral rights, we shouldn't have such poverty conditions. We shouldn't be living in third world conditions. So again, another point that I'm trying to make is treaties have been broken throughout time, and this is how we're laid out now. The viewpoint that we come from for generations now is that we prepaid for education, we prepaid for our healthcare, and you'll find out shortly that we were inadequately funded across the board: housing, education, and most importantly, healthcare. Next slide, please. This is a very horrific, important time in our history. This is the boarding school era, which is probably coming up a lot in your news feed in terms of the residential boarding schools where they're finding mass graves of children in Canada. We are having that. We have been going through the same here in the U.S. It just hasn't picked up that much steam. So this is a very hard-hitting photo. On the left, you see them in their traditional wear. On the right, you see assimilation and acculturation taking place. Next slide. I have to utilize this quote, and this was a 71-year era, and it was a partnership between the government and Catholicism, and their goal was to kill the Indian and save the man. And some data there for you all to see. So another case in point in terms of policy that was enacted, law was put into place to fulfill this initiative. Next slide, please. Another hard-hitting photo. This is to help you imagine your children being ripped from your households. Nobody wants to imagine that, can't imagine that, but it was very literal for us. In terms of the Sichango Lakota Oyate, the Rodbutsu tribe, we have a youth group that visited this place, and they found out that we have children still buried out there, whether they're identified or unidentified in terms of their graves. So they, through that prayer, through that passion, they're attempting to repatriate our relatives who are buried out there. Imagine, I'm sure they died from broken hearts. They died from physical and emotional and mental abuse. It's not all bad. My mother went through boarding school and made the best of it because that's what her grandfather told her to do. She's a first-generation University of South Dakota graduate. I'm second generation. My son doesn't know it, but he'll be third generation. And I've used him in a number of slides. He's not going to be too happy with me because he's in a diaper naked. But yeah, I'm very proud of him and what he's going to do in the future. We're raised to do better than what our last generations do. So I want to ensure that he has that path, that he does far better and greater than me. Next slide, please. So again, it's not all doom and gloom. We have beams of hope, and here's some really important information for you all to understand: past, present, future. The Schneider Act reaffirms the U.S.'s trust responsibility to tribes. The Dorgan report and an investigative report in terms of the horrific healthcare that we have in the Great Plains area. A lot of what was found in that is still happening because of inadequate funding, bureaucracy, thickly layered, a thickly layered agency. So it's important for us to think strategically and diplomatically to ensure that these partnerships and collaborations that continue to happen. Beams of Hope is the Mass General Rural Health Leadership that took Dr. Toby 3 years to get his foot in the door. Still happening, again, strategic and diplomatically. The University of Minnesota partnership, they really stepped up in terms of when MGH wasn't able to send students. I've had the honor of taking some of your pediatric residents on tours of the Rosebud Sioux tribe. To me, that gives them a better snapshot of the layout of our tribal homelands, rather than them just being in the hospital unit. And then the Indians into Medicine, as I mentioned before, we are a satellite office here at the University of South Dakota, which means we have 2 set-asides. We have 5 Native American doctors coming in, Native American med students coming in. It might be the most we've ever had. We're very happy about that and excited. And then we have Dr. Don Ward, a tribal public health leader. Next slide, please.
Hey, thank you, Damon. Damon spoke about the horrors of historical and intergenerational trauma. Yet we know that trauma doesn't just live in the past, it also haunts the present. And so in this next section, I'm going to be identifying and describing some pediatric health disparities that exist in a rural Native American community, and in particular in Rosebud Reservation. And I'll do that primarily through a visual means. Next slide, Mike, please. So this article and map in JAMA in 2017 attempts to show county by county across the country life expectancy. And you can see Minnesota up there in dark blue, up in the 80s of life expectancy in counties. And you can see some of the traditional areas we think about when we think about domestic health disparities. You can see the Mississippi Delta light up in red. You can see Appalachia. But near that sea of blue up in the north, you see just to our west, in South Dakota, 2 bright red counties with life expectancy in the 60s. And those represent Rosebud Reservation as well as Pine Ridge Reservation, our neighbors to the west. Slide, please, Mike. So as Damon showed earlier, 9 tribal communities in South Dakota. And these are where they're located. And we're going to use a visual representation. So you're going to see this map over and over again. But I want to point out that down in the green over here is Rosebud Reservation. The Rosebud Reservation is 1.5 times the size of Rhode Island, a population of approximately 20,000 people. Now, throughout the state of South Dakota, there are 900,000 people, and about 10% of the population overall in South Dakota identifies as Native American. You'll see a repeated pattern in the pictures and in the maps. And as we see that pattern, let's think about why. Why is that, and what does it mean? Mike, can you advance, please? Thank you. So when we look at all-call life expectancy, race is undoubtedly a factor. We see that American Indian, Alaska Native males have the lowest life expectancy by race in our country at 68 years, and females at 74. If you average those, the life expectancy of 71 would be comparable to countries such as Bangladesh and Iraq. Then you compound that with income data and county income data. And when you look at per capita income, counties in rural South Dakota represent some of the poorest counties in America. And Todd County is down there at $26,172 a year. Mike, can you advance the slide, please? So in 2006, Chris Murray, who's done a lot of modeling around COVID, did a model, what he called 8 Americas. And one of the telling quotes from that article, Mike, if you don't mind advancing, was this: when race county combinations are put together, so when you take race as well as county and income factors, you start to see these disparities expand. So for Native American males in the counties that we're speaking about, Bennett, Jackson, Millette, Shannon, Todd County, which is the Rosebud Reservation. Males had a life expectancy of 58 years compared to Asian females in Bergen County, New Jersey, a disparity of 33 years. So an astonishing compounding. Mike, do you mind advancing, please? So you're going to see this map. On the left is that pattern of where reservation lands are in South Dakota. And then you'll see maps on the right that represent health statistics. Darker colors are higher rates of whatever we're talking about. So when we talk about all-cause death rate, you can see Todd County and the number will be up above, and you'll see the US and South Dakota, and you can compare rate ratios pretty quickly. So you see that when it comes to all-cause death rate, nearly double that of the state of South Dakota. When you look at our babies, when you look at infant mortality, you're looking at a nearly double rate ratio in Todd County, as well as in other tribal communities. But it doesn't just apply to our smallest babies. The health disparities also affect our adolescents. When you look at teenage birth rate, we see a nearly 5 times rate ratio of teenage birth rate. Mike, do you mind advancing? There's an epidemic, a pandemic of depression, mental health concerns, as well as self-harm on reservation communities. And Todd County is by no means different. In fact, has one of the highest rates of self-injurious behavior in the country. When it comes to accidents, also motor vehicle accidents, you see a rate ratio that is remarkably higher out in these long expanses of road. Mike, do you mind advancing? So this is accidents and then motor vehicle accidents as well. So that's all. And then do you mind advancing, Mike? So as we dig deeper into the data and look at some of that early childhood data, the PRAM study, the Pregnancy Risk Assessment and Monitoring System conducted by the state of South Dakota, provides some context and some data. When you look at early and adequate prenatal care as influenced by race, income, and education, we see that our American Indian sisters are not getting early prenatal care comparable to other South Dakotans, and it is not nearly as adequate. Moreover, when we look at postpartum depressive symptoms, we see a significantly higher rate of postpartum depressive symptoms. And then tying it together with the historical trauma that Damon spoke about, when you look at ACE scores, nearly 50% of American Indian women who deliver in the state of South Dakota have 4 or higher ACEs, or adverse childhood experiences, connecting this historical trauma with present day health disparities. Mike, do you mind advancing? And this is just another way to look at the rate ratios from Todd County compared to South Dakota. Anything in red is a rate ratio of higher than 2. And anything in green is actually better in Todd County in terms of statistics. And that's only in Alzheimer's disease, which is, of course, a disease of the elderly. Mike, do you mind advancing? I've spent the last 5 minutes speaking about disparities. But of course, disparities are far more than numbers. It is about the stories of people and community. But we don't love Rosebud because of numbers or because of disparities. We love Rosebud because of people and community and family. There's a Lakota term, mitakuyo yasi. And it means we're all relatives. And that feeling of relatives and that feeling of community is I think, why many of us love Rosebud so deeply. These assets of family, tioshpaye, community, where you can know families, where you can do house calls, where you can know your neighbors. It empowers communities to do more. And so we've spoken about disparities, but really what brings us back to Rosebud is asset. It's this asset of family and community. And Rosebud has incredible assets. It has a group of community health representatives. It has public health nurses. And this sense of community leads to great possibility in terms of things that can get done. And so I just show one representation of that here. When in early vaccine rollout, the community did amazing things to make sure elders were vaccinated. And you can see here today, this is as of this week, The Rosebud vaccination rate for 65 and higher it was nearly double that of the average for state of South Dakota. You're going to hear a little bit more about some of these health infrastructure pieces and health administration from Dr. Sundberg.
All right, well, good morning, everyone. So my goal in the next few slides is to discuss the primary mechanism by which tribally enrolled children are able to access healthcare. And this is primarily through the Indian Health Service. And while there are other ways for children who are tribal members of federally recognized tribes to receive healthcare, including public and private health systems, UMMC is included in this, IHS does remain the predominant system overall. And IHS is a unique and also a really complex system in itself. It's the principal healthcare provider for about 40% of American Indian and Alaska Natives. It has a goal to provide care that's comprehensive and culturally acceptable. It also functions in many ways like a universal coverage system for enrolled members of federally recognized tribes. And while all tribally enrolled children are entitled to receive services, healthcare services from IHS, there are a lot of limitations in what those services look like. So for example, in Rosebud, access to specialty services, ICU or intermediate care, acute psychiatric care, and surgery all require referral or transfer. So to briefly review the structure of IHS, it has facilities that are both federally operated by IHS staff, and it also has tribally operated facilities, which occur when a tribal government undergoes a process of contracting or compacting funding from IHS, and that allows the tribe to determine how those healthcare funds will be allocated and administered. And this is done using the Indian Self-Determination Act or Public Law 93-638. So occasionally you'll hear that a facility is 638'd, which means that it's tribally operated. But when we look at the federally operated IHS, it's broken down into 12 areas for administration of healthcare regionally. You can see that in the map here. Minnesota is in what's called the Bemidji area, and that's with Wisconsin, Michigan, and Indiana. And then South Dakota is in what's called the Great Plains area with North Dakota, Nebraska, and Iowa, as Damon had mentioned earlier. And although we're not going to dive into this heavily today, it's also important to know there's an urban Indian health component to IHS that operates in metro areas, including in Minneapolis. And overall, IHS serves, as I mentioned before, about 40% of the total American Indian and Alaska Native population in the United States, and it has a user population that's around 2.5 million. And IHS has had some really important successes that are worth celebrating, as well as a number of challenges. So when we look at this graph that was published back in 2006, we can see that IHS has helped to bring down mortality on a lot of key indices during the period from 1978 through around the turn of the millennium. Death from tuberculosis, unintentional injuries, and heart disease, for example, have all really substantially decreased. But we also have to remember to take these decreases in the context of the general population or comparator populations. So while there have been a lot of successes, and again, we're celebrating, as you can see in this graph on neonatal mortality, where the black line represents American Indian Alaska Native population that's been adjusted for race misclassification, and then the dotted blue line represents the US white population, you can see that there are still a lot of differences in mortality rates. I mean, we're talking several deaths per 1,000 live births. And then this graph is just sort of a different form of displaying the same idea, this time for under 5 mortality. We can see extremely stark differences in mortality due to a number of reasons, but particularly unintentional injuries. So one of the big questions that I often find myself thinking about is why? Why in a health system that's essentially a universal coverage model and has financial investment that's predicated on treaty obligation do we find these differences? And I think the answer here is really complex, but perhaps some of the most common reasons might be noted, or what's noted here on this slide. First, many facilities are operating in really remote areas where access to the facilities can be really difficult for patients. This example table that you can see is a survey of 10 IHS facilities by the Government Accountability Office. And you can see that there's greater than 100 miles of required travel for patients to access at least 3 of those 10 surveyed facilities. The second issue is provider shortages. And this graph that you can see here represents total provider shortages in the different areas of IHS. So if we look at the Great Plains area, which you can sort of see in the middle, It's nearly 1 in 4 providers that aren't there that are needed to provide care. If we look at the Bemidji area, which is Minnesota, there are less overall positions needed, but it's about 1 in 3 providers. And the numbers, if we think about physicians in particular as healthcare providers, are actually substantially worse. So in the Bemidji area, it's nearly 1 in 2 providers that aren't there providing care that are needed. A third issue you can see on the left-hand corner, or the left-hand column, is provider knowledge about healthcare and cultural influences. And this is primarily a problem because there are so few physicians who themselves identify as Native American. Outdated infrastructure can also be a major issue. If we look at Rosebud in particular, the operating rooms, for example, are currently not operational. And for any rural hospital to resume the use of ORs, whether it's just rural or whether it's a IHS hospital, it's a major financial and logistical endeavor. And then finally, and probably the root of the majority of the issues above, is the funding structure for providing care through IHS. And I'm going to let Damon discuss this in more detail because he's really knowledgeable about the issue. But just to point out first that the graph you can see here shows IHS per capita spending compared to other entitlement and non-entitlement programs. And it's usually about half to a third of other programs. So Damon, go ahead.
Thanks. Yeah, this is a huge topic of why you'll see our leadership. Next slide, please. Why you'll see our leadership actually pound on tables, whether it's a consultation in the region or a consultation out in Washington, D.C. So we have here a budget overview. I got this from the IHS.gov website. It does have to be updated, but it's still a very good snapshot of the money we're getting. So I'm very aware from fiscal year 2017, 2018, 2019. We see our funding increased by 500 million, of funding increased by 300 million, and we're told to do cartwheels because we're getting that much more money. We are thankful, but that doesn't spread out. That spreads out very thinly to those 574 federally recognized tribes. You see in fiscal 2018, we got 5.5 appropriated. The true ask was 7.3 billion. So you'll see, there are different criteria of why they end up giving us what they give us. One of them that they don't include in terms of the training that I got is medical inflation. You'll never see that in the private sector. You'll probably never see that anywhere. So that's how it all breaks down. The true ask, the true need in terms of a need-based budget is 37.6 billion. So the hope is, as you see it increasing, that we get to that in 12 to 15 years. But what's the true need going to be then when we get to that point? Next slide, please. Another snapshot of how this funding trickles down. But as you can see, we're only 0.19% of the overall budget that comes from the Department of Interior, to the Bureau of Indian Affairs, the Bureau of Indian Education, and the Indian Health Service. And as you can see, this is how it all breaks down. Next slide, please. To me, this is a very important slide, very important information. I've heard our director of the Great Plains area talk about he's working on a 52-cent per dollar budget. And this is is very relative to what he's saying. Again, in terms of basic needs and living in a third world conditions and being inadequately funded really compounds the problems that we're dealing with. Next slide, please.
All right, thank you, Damon. Good morning, everyone. Thanks for spending time with us this morning to talk about this topic. In the next slides, I will talk about opportunities between academic institutions, tribal nations, and the Indian Health Services to create partnerships that are based in solidarity towards health equity for American Indian populations. I will highlight the work being done between University of Minnesota, the Rosebud Sioux Tribe, and the associated Rosebud Indian Health Service site. I've been very fortunate to spend clinical and community-based time in Rosebud this year, and I hope others will have the opportunity to continue this work forward. Next slide, please. A partnership between 3 independent parties carries inherent complexities. When these 3 partners are between an academic institution, tribal nation, and a federal institution, this carries both historical traumas and current day injustices into negotiations and collaborations, and thus can be very complicated. However, this is doable and it is needed. If partnerships carry a foundation of respect to the culture of the tribal nation, an acknowledgement of their sovereignty and governance, and additionally sustainability over time, this can breed trust, and thus these principles can lead to solidarity of goals. There are a couple of current examples of community academic IHS partnerships that already exist. These include ones between the University of New Mexico and the Navajo Nation, the University of Utah and the Navajo Nation, the UCSF and the MPhil Fellowship, and then a partnership between Mass General Hospital and the Rosebud Reservation, IHS. And they've actually created a unique Rural Health Leader Fellowship, which we, through University of Minnesota, work closely with. However, nationally, partnerships based in pediatrics is somewhat unique nationwide. Next slide, please. So on this slide, it's a little bit complicated and wordy, but I'm going to talk about the benefits across different levels of service. And I will provide some examples that we've seen at Rosebud. So when looking at direct patient care benefits, partnerships can help address provider shortages, such as staffing for inpatient and outpatient, provide coverage for overworked staff to promote wellness and retention, help with complex pediatric and adult patient management in the creation of shared patient panels. Looking broader at system-based benefits, these can include quality improvement initiatives such as supporting antimicrobial stewardship or electronic health record protocols and order sets, increasing access and use of medications such as buprenorphine for opioid use disorder, treatment for hepatitis C, and guidance for LGBTQ+ or two-spirited medication-assisted management, and also can lead to capacity development, specifically during the pandemic this was seen in the introduction of high-flow nasal cannula in order to help keep tribal members on the reservation. Looking more broadly at community and population health benefits, partnerships can be of service in the creation of public health messaging for topics such as immunization and COVID-19 campaigns, which we held via radio and social media platforms, as much as the tribal members actually use Facebook for their main communication with each other. This is also seen in writing grants in conjunction with the tribal health to promote COVID relief and suicide prevention, bringing Reach Out and Read into the clinic, and finding community partners to translate into Dakota language to preserve the native language, increasing tribal-based research efforts, and helping host community-based education and screening events, such as those that we did with Head Start last year. And finally, if we look even broader, partnerships can lead to an aid and advocacy for tribal sovereignty and health. And this can be done in such ways as school partnerships and mentorship, and promotion of pathways for increased Indigenous representation in the medical workforce. We can grow our own medical education by increasing specific content addressing Indigenous health and the delivery of care. And we can advocate for policies that impact the health of Indigenous populations, such as Medicaid expansion in South Dakota. Next slide, please. So what has the University of Minnesota and Rosebud done together? Thus far, the University of Minnesota has sent 13 residents out to Rosebud through the Pediatrics, Internal Medicine, and MedPeds residency programs since 2017. One of those residents is now working for the Chickasaw Nation in Oklahoma. 4 global health chief residents will or have spent time in Rosebud clinically and in the community, and 5 University of Minnesota faculty go out to Rosebud as part of their contract. We're also collaborating closely with the group from Mass General Hospital, as well as expanding to include participants from Hennepin Healthcare. Next slide, please. As far as our medical education, our Rosebud partnerships helps address the deficits in our medical education by increasing comprehension of the Indian health services and rural-based healthcare, increasing understanding of tribal sovereignty and tribal public health efforts, increasing recognition of Indigenous community-specific health determinants, gaining an appreciation of cross-sectional community-driven solutions on American Indian reservations, and overall building motivation for a career addressing these health inequities. Next slide, please. And while we're on the topic of education, I'd like to point out that University of Minnesota is a huge benefactor from the Morrill Act of the 1860s. This is where President Lincoln distributed public land or previously indigenous land acquired via violence-backed treaties to numerous higher education institutions. And University of Minnesota is one of the largest beneficiaries of this federal act. The map above demonstrates the land University of Minnesota acquired from this act, and the calculations below it highlight the large endowment generated from this land compared to what the US paid for the original indigenous title. You can see the return has been incredibly favorable, and we should probably think about how we can equitably share this wealth with indigenous people we originally acquired it from. University of Minnesota at large has actually elected Karen Driver to a new position as a senior advisor to the president for Native American Affairs, who will work with Tad Johnson, who's been there working for a couple of years as the senior director for the American Indian Tribal Relations. Next slide, please. So what are the next steps for the Academic Health Center at University of Minnesota? We should continually increase and adjust our medical education to include indigenous curriculum and narratives. We're actually hosting our first block education this Friday, looking at the healthcare of American Indian children and their families, where we'll be bringing in community programs and representatives. And this was arranged by our Dr. Steve Selinsky, myself, and Dr. Mary Owen. We're looking for partnerships with schools in support of Indigenous students' interests in medical careers. Some work has been done by Dr. Erica Ting in the Anishinaabe Academy here in the cities. And we also hope to create a University of Minnesota Twin Cities-based American Indian Health Task Force that can work with Dr. Mary Owen and her Center for American Indian and Minority Health. When we look at forming further partnerships, we should look just outside of our door to see if we can help the urban institutes that serve our tribal nations in our cities. This includes a Native American Community Clinic, or NAC, and the Indian Health Board, both here in Minneapolis. And then we can work with the 11 tribal nations within our state to form some partnerships. And finally, we should act in solidarity, be advocates and allies to support American Indian health and equity and keep our next 7 generations healthy. And this would include looking to support our colleagues in Line 3, policies affecting family separation, Indian Child Welfare Act, and housing policies. Next slide, please. And at this point in time, I would like to turn it back over to Damon for some final thoughts and words.
As you can see, we have a lot of information, great information in terms of opportunities and experiences and initiatives. We're running short on time. I hope we can still get some questions in the chat for us to possibly follow up on. I did put my email in the chat for anyone who feels the need to reach out. It means a lot, but I can't say how much it has been great for all of us to continue to collaborate and partner in terms of what needs to happen within our tribal nations, the assistance we need. As you can tell, there's resilience that we persevere, but that allows us to enables us to persevere. Yeah, there's great opportunities. It's a win-win across the board in terms of strengthening your CVs. It's a win in terms of upgrading or increasing the level of healthcare, and also bridging those gaps in terms of relationships we may not have. So I can't say that enough, how much this has been an honor to share with you all. Maybe we could take a couple questions.
I think Dr. Subrahmanian answered the question that Dr. Barnes asked in the chat, but I would just love to hear your reflections as well, Damon. He asked,
that is definitely integrated. IHS allow it. They do recognize that we have traditional ways of healing and medicines. So sometimes, once again, it's a spectrum. Either they go the traditional route, or they go the contemporary Western medicine route, or they go in between. And again, the Indian Health Service does recognize that and honor that.
I have a question. I always have the mic, so I can ask whatever I want. I just wondered, you know, it's an interesting partnership with some, sounds like healthcare providers from Mass General who come and work at Rosebud. And I just wondered about partnerships with the pediatricians in training at University of South Dakota, and if that's a relationship that either exists or you hope to strengthen in the future.
Definitely, I have to bridge those gaps as well with our Associate Dean, Dr. Danielle Kenyon, who used to be with Stanford Research. She's a great colleague, ally, worked with tribes for years. She's now with us here at University of South Dakota. She came on not too far before me. So I know her as a tribal health administrator and other work that I did through some grants that she attained. You know, when I was a health administrator, I am on record asking where USD is at in this picture. USD is in the American Indian Health Improvement Act, where there's a pilot project written in there. Obviously, there was no funding appropriated, but to develop a residency here, there's a lot of potential. Again, this should be happening 10, 20 years ago, my position, but you know, it's very timely that we're having these discussions. We're very close to getting some students out there to Rosebud, Mass General Hospital. That partnership has been very open to that, and it's just awaiting some of our students to start having those experiences.
Great, thank you so much. Well, I wish that we could have a whole hour for further discussion, because I think there's just so much that we could talk about. And really looking forward to the afternoon session that Dr. Lehman and Dr. Zielinski have helped to organize for this Friday for our residents in training. I think it's going to be a really powerful and important session. We have a ask for more grand rounds like this. Okay, noted. I think we can do that.
I'm only 5 hours away. I have family on the south side. I have family throughout Minnesota. I'd love to come. I'm very I know Dinky Town very well. I'd love to come and visit.
Yes, we would love to have you come in person. The virtual is never quite the same. Thank you so much to everyone for this really important education for all of us. And I think hopefully will leave us all motivated to do even more in the future. And thank you for all of the important work that you're all already doing.
Thank you, everyone.
Have a wonderful day.
Okay.
Bye.